Hello everyone, Dr. Buzzword here, and welcome to this teaching on hyponatremia, where we'll learn about the pathophysiology, how to investigate and manage people with hyponatremia. So let's get started. As usual, I have put a disclaimer saying that this is only for learning medicine and not to be used to treat people. Okay, so what do we mean by hyponatremia? Hyponatremia is defined as a serum sodium less than 135 millimoles per liter. Is the commonest electrolyte abnormality in hospitalized patients, and it is often due to excess water relative to the sodium. This is because the body prioritizes conserving water in order to maintain a stable blood pressure. Generally, there are three main causes of hyponatremia. One, it's a simultaneous loss of both water and sodium. Second is pure water gain due to inappropriate release of antidiuretic hormone, ADH. Or thirdly, it is due to low oncotic or hydrostatic pressure, which can lead to third spacing of water, and hence more water is conserved to store intravascular volume. Now, both loss of sodium and water can be due to diarrhea, vomiting, burns injuries, or diuretic use. And generally, the way I like to think about this are people are dry as a crisp. In people with inappropriate release of ADH, this can be due to brain injury, hypothyroidism, or adrenal insufficiency such as Addison's disease. The low oncotic and hydrostatic pressure predominantly is from either the heart, liver, or kidneys. So in oncotic pressure is due to loss of albumin, which can be from cirrhosis, nephrotic syndrome, or renal failure. And in low hydrostatic pressure, there is a pump failure of the heart, so it's unable to maintain the pressure to excrete the fluid from the body. In people with inappropriate release of ADH, they are plump as an orange, and in people with low oncotic or hydrostatic pressure, they are very wet. Now, if we, for understanding purposes, put a ratio of water to sodium, generally people who lose both sodium and water typically have a ratio of 1:1. And in people with an inappropriate release of ADH, the ratio of water to sodium is about 2:1. And in people who have low oncotic or hydrostatic pressure, the ratio is about 5:1 or more. So there's much more water in the people with low oncotic and hydrostatic pressure. Now, how do people present? People with hyponatremia generally present with neurological symptoms, and the severity of the neurological symptoms depends on the severity of hyponatremia and the acuity of onset. Milder symptoms can be such as nausea, having a headache, and people having poor concentration. In moderate hyponatremia, people start becoming confused, a bit drowsy, having muscle cramps, and people with severe hyponatremia can develop seizures, have respiratory arrest, brainstem herniation, or even can go into a coma. Now, this is a medical emergency which needs to be treated straight away. Now, how do we investigate for people with hyponatremia? Volume status is the main starting point, so go see the patient first. You can clinically categorize these people as whether they are hypovolemic, euvolaemic, or hypervolemic. Depending on how you assess, you can also send for bloods. This includes urea and electrolytes, kidney function tests, also sending urine osmolality, urine sodium, and serum osmolality. And also try and identify the possible causes. Why did the patient present to the hospital with hyponatremia in the first place? Or what have you done to the patient that has caused this hyponatremia? Other things to also add on to blood tests are thyroid function tests, measuring the 9 AM cortisol for adrenal insufficiency, and also to investigate for either malignancies or inflammatory disorders using imaging such as a CT chest, etc. Now, what do? Like I mentioned, the first thing to do is to assess the fluid status of the patient. Now, people with hypovolemia can either have a postural drop in blood pressure, the lying standing blood pressure, LSBP. People can have tachycardia and also have a dry oral mucosa. People who are euvolaemic, i.e. they don't show signs of both hyper or hypovolemia, would generally look normal from a clinical perspective. And in people with hypervolemia, they tend to have pitting edema, ascites, and crackles and auscultation because they are third spacing, i.e. the water is getting removed from the intravascular space and into the extravascular space. Now, how do you interpret serum and urine osmolality? Serum osmolality is calculated by this formula: 2 times the sodium plus glucose and urea. In hospitals, the labs can measure the actual serum osmolality. Remember, the calculation is just a theoretical measurement of the osmolality, but to get an accurate measurement, you can send requests to the labs. Now, in people with hypovolaemic hyponatremia, generally present with the serum osmolality that is either in the low or sometimes in the normal range, and with a urine sodium that is normal. Now, people with Euvolaemic hyponatremia have a normal serum osmolality. However, the urine sodium will often be raised because the ADH conserves the water, and so there is less urine produced, and hence the urinary sodium increases. Now, in people with hypervolaemic hyponatremia, the serum osmolality is often low because they are fluid overloaded. There's too much fluid in their body, and the urine sodium is often normal. Now, how do we manage these people? The aim of managing hyponatremia is a slow and steady process, and hence the quote, "slow and steady wins the race." Now, why is that important? Because rapid correction of hyponatremia can cause osmotic demyelination syndrome. What this means is when there is a high amount of salt that is put into the intravascular space, water can be absorbed back from the cells, and this can make the cells shrink. And this is what we call as osmotic demyelination syndrome. And especially if it's in the brain, it can cause neurological problems. The aim is to increase the serum sodium by less than 10 millimoles in the first 24 hours. And after the first 24 hours, you need to increase the serum sodium by less than 8 in every 24 subsequent hours. Now, how do we do this rapid correction? So when you do the clinical assessment and use the serum osmolality and the urine sodium, you can diagnose people if they're having hypovolemic hyponatremia. Now, once you diagnose that, the management is quite straightforward. You give them IV saline, 0.9% sodium chloride, and like I mentioned, monitor the sodium closely. It can be given generally over 12 hours to see how they are responding. In people with hypervolemia, i.e. too much fluid in the body, the importance is to remove the excess fluid. Now, how can this be done? You can fluid restrict the patient to about 1 liter to 1.5 liters per day. And you can also consider giving loop diuretic, such as furosemide. Now, why is the salt restriction? Remember, when there is salt, when you add salt, more water is conserved. So you don't want to add more salt to give more salt to these patients, because they're going to just conserve more water, which is not the aim of the management. There is more dilution of the sodium here. Again, identify the cause of hypervolemia. If it's heart failure, try and manage the heart failure. If it's a nephrotic syndrome, contact the renal specialist about managing the renal disease. And if it's liver disease, again, manage the liver disease as appropriate. Now, people who are euvolemic often is due to SIADH. The first line management is to fluid restrict them to about 1 liter or 1.5 liters per day. The second line is to actually give them oral salt tablets. Yes, they do exist. It's literally salt in a tablet. You can also consider giving a drug called demylination, which counteracts the effects of SIADH. And if those 2 lines don't work, you need to speak to endocrinologists, who will probably start on medications such as tolvaptan. Now, management of acute hyponatremia is slightly different to chronic hyponatremia. The reason being is that people with acute hyponatremia can have severe symptoms such as seizures, coma, and with a GCS less than 8. And the aim of management is to treat the symptoms rather than the sodium level. So in this scenario, you want to treat the symptoms ASAP. Why? Because the risk of death from cerebral edema outweighs the risk of osmotic demyelination syndrome, or ODS. The management is to give hypertonic saline, roughly about 150 ml of 3% sodium chloride. However, this can only be done in a level 2 or level 3 setting, such as a high dependency unit or intensive care unit, over 20 to 30 minutes. And the goal of the management is to give a rapid increase, but a small increase in the sodium over the first few hours to reverse the acute cerebral edema. And as you can see in this image, this is what happens. So that concludes hyponatremia. I hope you enjoyed this video. If you did, please make sure to like and subscribe. and I will see you in the next one. Have a good day.